So thank you for this opportunity to speak today in this seminar. So I'm going to be discussing genomic testing for colorectal cancer. My name is Mike Braun. I'm a consultant medical oncologist at the Christie Hospital. So the background is that for many years there's been some genomic testing performed, initially within clinical genetics and then latterly in oncology. But over the years, the role of genomic testing has increased markedly, and now the implications, particularly in colorectal cancer, are that genomics can impact on screening for patients in terms of Lynch syndrome, also decisions regarding extent of surgery, particularly for Lynch syndrome patients, but also importantly, now starting to impact on treatment decisions in terms of preoperative treatment, palliative treatments and dosages of treatments that can have implications on patient discussions at MDT meetings and what decisions are made for patients' treatment overall. So it's important that the whole MDT has an awareness of the importance of genomic testing. It's also fair to say that genomic testing is developing rapidly, and the tests that we're using now, it's likely that we'll be introducing new and additional tests over the next few years. So the impacts of genomic testing are likely to increase. So in terms of what genetic testing is available, there is a national test directory which NHS England produce and is available via this website, which lists approved tests and indications for the testing. This is an excerpt from that test directory, which is specific for colorectal cancer. You can see this is quite a busy slide, and it's trying to list all the different genes, but also the different techniques that can be used to assess those genes. So it's relevant not only to clinicians, but also people within the lab who are trying to ensure the testing is done to the correct standard. I'll try and pick out the main ones of interest clinically over the next few slides. So the first area we're going to look at is mismatch repair status. This is key in terms of screening for Lynch syndrome, and we know that approximately 10 to 15% of all colorectal cancers are mismatch repair deficient, with approximately 4% of patients having Lynch syndrome after subsequent testing. And over the last 6 to 7 years, there's been a drive following NICE guidance to have routine MMR testing of all colorectal cancer patients at diagnosis as a way of screening for Lynch syndrome. But as described here, we know that there's a significant additional proportion of patients who do not have Lynch syndrome, but mismatch repair deficiency is a feature of their tumour. So when we start looking at how mismatch repair deficiency is now impacting on treatment decisions, a good example is data that's come from the Foxtrot trial. So this was a study in colon cancer patients with locally advanced tumours, where the standard treatment would be surgery followed by post-operative chemotherapy. And the trial attempted to look at patients having a 6-week period of preoperative chemotherapy prior to their surgery. So the main question the study was asking was whether neoadjuvant chemotherapy, so preoperative chemotherapy, helped improve cure rates. And the answer from the study overall was that yes, it did, but interestingly not in mismatch repair deficient patients. When analysis was done of mismatch repair status in the trial, it was seen that just over 20% of these locally advanced tumours had deficient MMR status. Pathologists blinded to what treatment the patient received looked at the degree of response using accepted response grading criteria. And as is shown in this panel, when you look on the far right-hand side at the deficient MMR tumours, which are at the blue columns, had a significantly higher rate of no regression seen with preoperative chemotherapy. so approximately 70% of patients not responding, compared with just under 30% of patients who had chemotherapy. Importantly then, when it was assessed in terms of survival outcomes, patients with deficient MMR also had no difference in their ultimate survival with preoperative treatment, compared with patients who have retained expression of mismatch repair proteins, where a difference in response to treatment was seen, and in terms of longer term survival. So we've got evidence that our standard chemotherapies may be less effective in MMR deficient tumours from the Foxtrot study and also from some other trials. One type of treatment that does seem to be very, very effective in MMR deficient tumours is immunotherapy, and this is a relatively new treatment. It's been around now for about a decade and is being used in a range of different tumour types. But deficient MMR tumours appear to be one of the types of cancer which is most sensitive. Our evidence for benefit of immunotherapy initially comes from a trial called KEYNOTE-177. So this trial took patients with MMR deficient tumours, they were all colorectal cancers, and patients had either standard chemotherapy or a 2-year course of an immunotherapy drug called pembrolizumab. The main endpoints of the trial were looking at progression-free survival, so how long the patient remains without worsening of cancer, and overall survival. This figure shows that patients receiving pembrolizumab, so the immunotherapy drug, overall had double the length of time until cancer progressed, so 16.5 months compared with 8.2 months for those receiving standard chemotherapy. You can note that in the first 3 to 4 months after commencing treatment, chemotherapy is slightly better than immunotherapy, but then there's approximately 60% of patients who benefit from immunotherapy, and as is shown on the next slide, a large proportion of these patients who have had initial response remain without progression in the long run. You can see a dashed line at the 2-year point when patients complete the course of immunotherapy treatment, and beyond that you can see a longer term plateau with approximately 70% of patients not having disease progression identified at any point so far. So this is really a game-changing treatment for patients who previously would have had poor outcomes with our standard chemotherapies. In terms of treatment for operable cancers, there's increasing evidence from small studies, and I've listed 2 main ones here from patients with colon cancer, but also rectal cancer. And there are now multiple ongoing trials looking at whether immunotherapy treatment preoperatively is helpful for patients with deficient MMR tumours. This is the first trial, the NICHE-2 study, which looked at a 5-week course of immunotherapy given prior to surgery using 2 different immunotherapy drugs. And this was performed in the Netherlands. The patients generally had very locally advanced tumours, so a high proportion having T4 cancers and patients who are heavily node positive. These figures show the significant responses that were seen. So 99% of patients had a pathological response. 95% of patients had a major response, so there was less than 10% viable cancer left at the time of surgery. And 67% of patients had no viable tumour left at the time of resection, despite this being a very short period of preoperative treatment. So again, reaffirming that these tumours appear to be exquisitely sensitive to immunotherapy treatment. rectal trial is quite a small study and was aiming to give 6 months of immunotherapy treatment with a different immunotherapy drug to that which was used in the niche trial. Depending on response to treatment, patients would go on either to have surveillance, or if there was residual tumour, have radiotherapy or surgery as required. Initial results from the first 14 patients included in this study showed that all patients went on to have a complete clinical response based on MR scan and clinical examination. And to date, with further follow-up, additional patients have also been confirmed to have complete responses, and no patients to date have progressed following completion of treatment. Again, re-demonstrating the benefits of immunotherapy for this patient group. So in summary, for MMR deficient colorectal cancers, it's vital that we do MMR testing for our patients. The results, as we've described so far, enable us to screen for Lynch syndrome and then expand that testing to look within families. And from an oncological and surgical point of view, the presence of MMR deficiency opens up the potential to give patients immunotherapy currently in the palliative situation to try and control disease. But it's likely, given the results of these small studies I've shown already, that immunotherapy will continue. The immunotherapy's role will continue to expand and be used in earlier stage disease, potentially as a definitive treatment. Thank you.